Without further ado, let's welcome to the stage Jami Snyder, Director of Access.
Thank you, DJ. It's a pleasure to be with you this afternoon. I'm going to talk a little bit about the work we've been doing over the course of the last several years, kind of where things sit currently and what the path ahead looks like. So many of you have been on the journey with us, and so welcome an interactive conversation if you have questions about anything that I covered in today's presentation. So access by the numbers. You all are familiar with these numbers. 1.9 million enrollees approximately within the Medicaid program in Arizona. We cover 1 in 4 Arizonans, over half of the state's births, and 48% of Arizona's children. As you know, cost containment is our middle name. We talk about that a lot at Access, and my predecessor was really committed to ensuring that we ran a program that not only sought to improve health outcomes, but also was an efficient program. And so you can see how we stack up against the nation in terms of cost per member per year. On average, in Arizona, we're right around the $6,000 mark. Nationally, it hovers right around the $8,000 mark. So really proud of our success in that respect. In terms of examining the road behind us, so we have been on a multi-year journey around healthcare integration, really looking to integrate care and allow individuals to access the full continuum of care and services in one place. And so when we look at the model, it's really about aligning the benefit at the policy level within the agency, and we saw the merger of DBHS and Access several years ago, which has helped in that respect. Aligning at the payer level, the most significant move in that regard clearly was October 1 of last year when 1.5 million enrollees moved into an integrated product for both their physical and behavioral health services, and then integrating at the provider level. And that's the piece of the journey that we're really engaged in now through our Targeted Investments Program, which is a $300 million program over the course of 5 years that we've folded into the Medicaid framework in Arizona through our 1115 demonstration waiver, which is really focused on integrating care at the point of service so individuals are able to access that full continuum when they seek clinical support at the provider. This provides you with simply the roadmap that has been our journey over the course of the last several years. When we began in earnest in 2013 with the integration of care for the CRS population, moving up to 2018, as I mentioned, where we transitioned 1.5 million enrollees into a fully integrated product. So now that we've been on that journey, we really feel like it's important at this juncture to look at whether the model we've endorsed over the last several years is working for members that we serve in the Medicaid program. So when you think about integration, there were a few goals that were really prominent in our mind when we began down this road and continue to be markers of success for us and indicators that we measure ourselves against. Reducing fragmentation clearly, managing utilization, improving access to care, and I'll talk a little bit more about that in terms of our current efforts in a moment, and then improving the member experience of care. So as a result of or as a part of, rather, our 1115 demonstration waiver, our last waiver, we were required clearly to evaluate the integrated care model that we endorsed for individuals determined to have serious mental illness in Maricopa County, which was that 2014 integration effort that occurred for the SMI population. We have finalized a report on that particular integration effort. Mercer assisted us with that report. And when you look at the results coming out of that study, you can see that in terms of ambulatory care, preventative care, and chronic disease management, we saw some notable improvements, including a 2% improvement in access to preventative or ambulatory health services, a 4% improvement in chronic diabetes care, a 35% improvement in medication management for people with asthma. Some really impressive results on that end. Member experience of care, as important to us in terms of measuring our success with integration. In terms of rating, and this is the CAP survey, many of you may be familiar with. Individuals fill out the survey, and we work with our health plans to complete those surveys among our membership. Rating of health plan, a 16% improvement shared decision-making, a 61% improvement, and coordination of care, a 14% improvement. And I think in particular that shared decision-making piece, we were really happy to see the improvement on that end, because that's a big part of the equation when we talk about the success of integration in our system. Hospital-related measures, we saw a bit more of a mixed bag. Emergency department utilization, we did see the kind of decline we would hope to see, with a 10% decline in ED utilization. Readmission rates, we saw a 13% decline, again, improvement on that end. But with inpatient utilization, we saw an increase of over 100%. So we're now evaluating why that increase occurred. Notably, Mercy Care Plan conducted their own study, and they've been able to share the results of their study with us, and saw very similar outcomes with their study in terms of improvements along the ambulatory care and preventative care measures, improvements in terms of member experience, but also that concern around inpatient utilization. So we're continuing to explore why that occurred, and are really committed to continuing to evaluate the subsequent integration efforts that occurred for the SMI population in Greater Arizona, and clearly the remainder of the population that moved into that integrated model on October 1st of last year. Acknowledging the road we're on. So where are we at today? So one of the, as I mentioned, with our SMI effort in Maricopa County, one of the factors that we look closely at is members' experience of care. And right now, our focus is primarily on our targeted investments program and ensuring that at the point of service through the targeted investments program, where we're incentivizing providers within their clinic locations to integrate care and offer the full continuum of supports and service, that members' experience is what we would anticipate, that they feel like, in fact, they are able to access the services and supports they need when they walk into that clinic location. One of the most exciting efforts in that regard has really been the justice clinic sites that we've set up around the state. We've set up 13 justice clinics where we are co-locating not only physical health and behavioral health providers, but also parole and probation officers. And so through that effort, we've been able to offer services sometimes to individuals who have never, in fact, accessed primary care in their lives. So the story that stands out to me that my team brought to me a couple of months ago was a gentleman, 46 years old, went to one of our justice sites in West Phoenix, in the urban area here, walked in to see his parole officer. His parole officer right away, in the context of their visit, their routine visit, noticed that there were some clear physical health needs for this gentleman. And in talking with the individual, realized that this particular gentleman had never seen a PCP in his life. So for the first time at that very location, he was able to see a primary care physician and didn't have to leave that office setting to do so. And so that's the kind of benefit that we're really starting to see from targeted investments. So we've also had a team of individuals documenting some of the experiences of individuals, our members in our program, that have been served at those justice sites. And I was hoping to share a video with you today of one of those experiences.
My father was being chased for an undercover drug operation. He was running from the cops. Shortly after my dad was incarcerated, my mom had my brother, and that was the first time my dad saw my brother, was behind a wire fence at visitation. And I didn't know that wasn't normal. The first time I got caught breaking the law, I was in the 4th grade. 8th grade year, going into 9th grade, everybody was like, hey, let's get drunk. And that was the first time I had drank. There was something inside of me that I wasn't okay with, and I used these things outside of me, like people and liquor, drugs. I used these things to try to make me feel better. And it never seemed to do the trick. I always needed a little bit more. I didn't know that I had an addiction. I didn't know that in my genes was someone who was bound to be incarcerated and drug addicted. I became a very serious IV meth user. I was smoking a lot of crack. I was doing a lot of robberies. I was a very shady individual. I was not to be trusted. When I look at these new clinics and the way that these satellite offices are embedded into the parole office, I think of like main control for reentry.
For those coming out not knowing where to start, not knowing what they need to do, having our probation staff educated on who to reach out to and kind of focus on what's most important and work on one thing at a time will help them succeed in the community. And that's where the Target Investment Program has come into play. That really closes the gap with communication and closing the gap for services. So we're not having to reach out to all these different providers, giving them a list of all these different names and numbers. It's just one place they need to go and everything can get handled here, which really helps improve the outcome for our clients.
The collaborative effort as the entire team helps the client with any services that they need. I received a phone call as I was leaving yesterday, and the person thanked me and for coming in and helping them. And I said, "What made you come to us?" He goes, "I knew you'd help us."
A peer support specialist can kind of join with that person and say, "Hey, I'm going to walk this path with you. I'm going to walk this journey with you side by side." And so when you hit a bump or hit a snag, I can maybe share my experience of how I navigated that challenge. And it's really critical to have somebody that's kind of been there, done that, to say, "Hey, you can get through this. I've been through that too, and I know the way out."
You haven't lost your humanity because you've ended up in jail, and you know, I validate them. I validate their pain, and I, you know, validate their experience, and I validate their humanity, which they, you know, a lot of times they'll come out just apologizing and thanking me, you know, and it's like, so one thank you is enough. You haven't lost your humanity, you have a need, and I'm here to provide you with that service to meet that need.
They could have given up on me rather than giving me that second chance, and because of the second chance, I'm doing so well today. Like, I'm so grateful for it. Like, seriously, I want to cry.
All of that's happening under one roof, like with a whole team of people who have defragmented the whole system. And ultimately what we want to be able to do is walk in there and have access to everything under one roof.
So really exciting. That's what it's all about for us at this point, is really working to continue our support for providers as they seek to integrate care at the point of service. So really wonderful to hear the words of members that we serve in terms of their experience and their improved experience of care. In addition to the work that we're doing currently around the Targeted Investments Program and incentivizing providers for integration at the point of care, we do have a few decision points in front of us today related to our ongoing work to integrate care at the payer level. Most notably, on 10/1/21, we will make a decision, and prior to that time, but we'll go live with our REBA model that we endorse based on community input that we are now soliciting around what that regional behavioral health authority model should look like. We conducted a request for information, solicited information from the public, and received responses. And on our website now, we have posted a summary of those responses. And so this provides you with a bit of an overview of what we heard from the community through the RFI process. And we heard from managed care organizations, providers, stakeholders, in the RFI process. So you can see that approximately 50% of respondents really supported the idea of choice when it comes to our Regional Behavioral Health Authority product, and most notably offering choice to individuals determined to have serious mental illness that reside in urban areas. In addition, most respondents supported a single plan or entity to have administration authority or management over non-Title 19 services, so services that are not Medicaid compensable. Also, one of the important themes in the RFI responses was really around tribal sovereignty and ensuring ongoing tribal involvement, in particular when we make decisions that may impact tribal choice of services and supports and tribal choice of health plan. Also, support for a single entity, much like non-Title 19 services, that would be responsible for the first 24 hours of crisis. The majority of respondents echoed that sentiment through their responses to the RFI. And then support for a single 211 to manage crisis services statewide. And then notably, a recognition of the need of all plans, including ACC plans, to really employ a recovery and resiliency model. So we received some really good feedback through that request for information, but we will be conducting a series of community forums over the course of the coming months to really obtain feedback from notable stakeholder groups, and most importantly, from members that we serve and family members of individuals that we serve. So welcome your presence at those community forums as we move forward in obtaining additional input. But when we talk too about where we're at currently in our journey, we look at a number of data sources. One of the data sources that I've been looking at recently is the Leading States Index, which is a study that's conducted by McKinsey & Company, often looked at by states across the country in healthcare and a myriad of other areas. But in the healthcare arena, they looked primarily at three factors: healthcare access, healthcare quality, and public health. And when you look at the national average versus the peer average really compares us to states in our region, including Colorado, Nevada, New Mexico, and Utah. You can see where we stack up from a public health and healthcare quality perspective. Arizona performs well. Well, when it comes to healthcare access, we still have challenges in this state, and I think we all know that. Challenges pertaining to certain provider types, including developmental pediatricians and psychiatrists, and challenges more notably in rural areas where individuals really struggle sometimes to access care. So we've been having a lot of conversation within the Medicaid program about how we can enhance individuals' access to care while continuing to maintain the efficiency of the program. And in fact, those two factors go hand in hand with the next two efforts that I'm going to talk about. One is non-emergency medical transportation, a really challenging benefit to administer, I think everyone would agree, and continues to be an area of much discussion at the agency. On May 1st, we went live with the addition of a new provider type, which will allow rideshare into the marketplace. What we know is that many of our beneficiaries, outside of the provision of Medicaid services and obtaining Medicaid services and supports, already take advantage of Uber and Lyft and other rideshare sources that are available in our communities. So this is really opening up the non-emergency medical transportation benefit to rideshare, allowing those rideshare companies to register as providers with the hope that we will be able to increase the capacity of NEMT providers in our system to meet the need. We've struggled in recent years to, in fact, meet the need, in particular in those high volume months in the Valley and in southern Arizona around spring break, the February, March, April period. So our hope is that transportation network companies will be able to meet that need and free up some of the resources from traditional NEMT providers, understanding that there's a contingent of the population that really can't be served by TNCs. TNCs will focus more on ambulatory populations. Traditional NEMT providers will continue to focus on the continuum of members that we serve, including individuals that really need that door-to-door assistance. So what's exciting about this move for us is that we really feel like it's going to move the needle in terms of enhancing access to care, and we're able to do so at a lower cost. So really exciting work on that end. In addition, we're looking at the expansion of our telemedicine benefit, and this comes straight from you all. We've heard loud and clear that our telemedicine policy historically has been too narrow in its scope, and we've really had it limited to a core set of services and providers that could offer telemedicine. On 10/1/19, we'll expand that benefit to allow the full continuum of providers to offer telemedicine via interactive video, audio, and data communications, and then expand the allowable place of service for both beneficiaries and providers originating in distant sites to allow them to obtain services from a wider variety of locations. And so that too is exciting in that clearly it's focused on enhancing access to care, but at a lower cost, preventing some of those trips that we routinely hear about. The example I always give is Mojave County, where individuals are regularly transported to Las Vegas or Phoenix for services when telemedicine could provide at least some of that service and support to individuals. So one of our other efforts to access care. Planning for the road ahead, and this is where certainly I'm really excited about some of the efforts that we're looking at. The data point that we reference all the time, only 20% of individuals' health outcomes can really be attributed to the clinic visit, 80% attributed to other factors such as food insecurity, housing stability, educational attainment, employment, and so forth. So looking at the full continuum of variables that can impact health outcomes and how we as a Medicaid program can support that work. The good news is we have been working in many of these spaces for some period of time, including with our justice work, not only in the TI arena, but prior to the Targeted Investments Program and standing up the Justice Clinic sites. We established a Justice Reach-In program where we asked our contracted MCOs to effectively reach in to and start supporting individuals before they leave correctional settings, and they've been able to reach approximately 5,000 individuals through that effort, ensuring that they're connected to care upon departure from that correctional setting. In the area of housing, doing a tremendous amount of work, primarily due to the significant state appropriation that we receive each year to support rental subsidies, as well as development and rehab of properties. So you can see the results that we have now from plans like Mercy Care, serving 606 members, or housing 606 members, saw a 20% decrease in psychiatric hospitalizations. United Healthcare partnered with one of our community organizations, Chicanos por la Causa, to establish an integrated apartment unit. 100 of our members housed in that unit alongside 400 members not served by the Medicaid program, saw a 58% reduction in total cost of care for the individuals housed in that particular setting. So some really impressive outcomes in that arena to date. Community reinvestment. We have a contract requirement that mandates that managed care organizations reinvest 6% of their profits in the community. I'm happy to report that our contractors are coming together now to talk about ways that they can pool that funding to have a real impact when it comes to addressing other factors that affect individuals' health outcomes. And provider opportunities. I talked about our Justice Clinic sites. We also have milestones in our Targeted Investments Program, which speaks specifically to outreaching to community resources that could be of value to individuals served by the Medicaid program, and screening, most importantly, for social determinants of health. And then coding for social determinants. As you probably know, last year we released some guidance encouraging providers to properly code when they found that an individual in the context of a clinic visit had a social determinant need. We've begun to evaluate that data, and a couple of areas are surfacing as areas of need for our population. One area, familial conflict, really rose to the surface. Homelessness, unemployment, education, and literacy. So what does that mean for us as a Medicaid program looking forward into the future? What it means from my perspective is, as you know, and as I've demonstrated, our managed care organizations, our health plans have been doing a tremendous amount of work in this area. Providers throughout our community have been very proactive in the social determinants space, including federally qualified health centers and other providers. But what we really need to do at this point is think about how we can properly leverage technology to support providers and plans efforts around social determinants of health. There's a number of tech firms that are eager to ensure that providers are able to, in fact, address social determinants in a way that does not interrupt their workflow. So in March, we hosted what we called the Medicaid Innovation Challenge, partnering with an organization called Adaptation Health. We heard from 8 vendors about their efforts to, in fact, develop a technological foundation under the work that providers are doing to support individual social determinant needs. Very exciting opportunities, really the full continuum of tech solutions were really displayed at that event. One of which I think most notable, technological platform which essentially integrates with providers' EHRs. A clinician goes into the EHR, they're able to see the SDOH screening tool, click on the member's need, for instance, food insecurity. When they click on that button in the screening tool, automatically pings the referral database. Referral database reaches out to the social service organization. Social service organization reaches back out to the member, and they're able to close the loop in terms of offering and fulfilling that individual social service needs. So that's the kind of tech solution we're looking at to support providers' efforts and plans' efforts in this arena. And what does this mean for us going forward from a waiver perspective? So as many of you may be aware, other states already have been successful in obtaining federal support for their work in the social determinants realm. Most notably North Carolina, $650 million waiver approval recently, specifically to address social determinants of health for the members that they serve. The good news is we have a waiver renewal around the corner. So we are due to renew our 1115 demonstration waiver on October 1st of 2021. The draft waiver is due to CMS on September 30th, I should say, of 2020. So right now, we are looking at how we can effectively demonstrate that this work is important and meaningful to our community and actually ultimately will help us to reduce the overall cost of the program. So we're working with a handful of community partners and a convener, Vitalist Foundation, to talk about how we can support this work in the interim with the hope that we can integrate the concept into our waiver renewal package and support this work in a more comprehensive manner going forward. So really exciting stuff on the horizon. I'm working with many of you already to explore the opportunities in this area, and I know there are a number of community partners that are headed down this path on their own already. So it's really about coalescing that work, demonstrating a proof of concept, and showing how efforts to address social determinants will really make a difference in the lives of Medicaid enrollees in Arizona. So with that, I will entertain questions. I think DJ was going to come up and ask me a few questions.
Well,
to round out the-
let's give her a round of applause. Nice job. Let me ask you sort of this question. There's a lot here. There's a lot that's innovative. It's the same kind of question I asked earlier, folks, which is, with all of the distractions and all of the demands, what is the thing that you're spending your mental energy on? Maybe personally, because you've just outlined a lot of stuff here, and let me not mean personally, but I mean the thing that is sort of most interesting to you professionally, even though you've got all this other stuff going on that I know is engaging. What is it that stands out to you?
Sure. Well, today it's the budget, but that's just today's occupation, my brain anyway. But more globally, I really think the work that we're doing in the housing arena is exciting, and in particular, we're engaged in a project right now as a part of a governor's breakthrough project to focus on the really notable uptick in chronic homelessness in Maricopa County, so the county we sit in right now over the course of the last couple of years. So in an effort to address that need, we have partnered with Mercy Care Plan, one of our contracted managed care organizations, and one of their providers, Community Bridges, to house 275 people over the course of the next 2.5 years. And when I say people, I specifically mean individuals who are chronically homeless, who have lived on the streets for years, and where the real gap in terms of ensuring that they're able to obtain and remain in stable housing is engagement. And so it's really been a learning process, I think, for us as a Medicaid program over the course of the last several months in terms of understanding what the needs of that population are. And it is really clear that engagement's the key. So learning from CBI and from Mercy Care that oftentimes the biggest barrier can simply be with an individual that's been on the streets for years is going to the MVD to get a license. Standing in line for an individual who hasn't had to stand in a line in that sort of forum for 20 plus years is novel and challenging, or making sure that they have the other necessary documentation to sign a lease to effectively get into an apartment, making sure that we address chronic conditions that have been present in their lives for years but untreated because they weren't accessing services on a routine basis. So I'm happy to say that our goal for the first year is 100 individuals housed, and we've already referred 58 individuals to housing over the course of the last 4 months. So really exciting work on that front, and has tremendous potential, not only in terms of improving health outcomes, but also, of course, reducing the cost of care.
Yeah, and do you know, or do you expect, it wouldn't surprise me if you know, but how much of the state, the general fund state allocation to the housing results in an offset to general fund state Medicaid? Meaning, how much are you able to pay for the investment with the non-federal match on the housing side? How much of that results in a cost savings to the state?
So I think we only have preliminary results and have not really looked at that in the aggregate in a way that we can measure it as an offset, I would say at this point. But that's something we're really looking at in preparation for this waiver request, because I think we're going to have to be able to demonstrate, outside of the results that are the data that our health plans are collecting, specific to individual projects that they're engaged in with the rental subsidies and development rehab dollars that they have, we need to better coalesce around how meaningful is this for us as a community across the state. And so that's that proof of concept that I mentioned heading into the waiver renewal.
Awesome stuff. Questions for Jami from you all?
Hi, Jami.
Hi.
It was nice to see that Access is transforming and being progressive as we move forward. Thank you very much. The question I have is, you mentioned technology and you also mentioned telemedicine or telehealth. Is telehealth going to cover, or do you think it will cover, if the provider goes into the home setting to meet your member where they need their care?
So give me a bit of a sense of kind of how you see that working, and from a telemedicine perspective. Are you speaking outside of telemedicine, just in-home care generally?
No, I'm really truly talking about, well, technology, which I know you understand with diabetes, just heart failure, but actually having a mobile telemedicine type of service where many of the patients are homebound or have difficulty with transportation because of various medical issues, that we could actually do that in the home, telemedicine, the home setting.
Oh, okay, yes, and that's exactly the point, in fact, of the telemedicine expansion effort that we're engaged in for 10-119, to allow the distant, and I think it's receiving site, the individual and the provider to really operate from the environment that works for them, including individuals accessing services from their home.
There you go.
Comment and a question. When I was the Access Director, all my briefings were using overhead projector. You've come a long way since then. Good briefing. In some of the conversations in the breakout sessions beforehand, we talked about the waiver for the work requirement. Would you like to just comment on where that's at, where it's going?
Sure, absolutely. Lynn is referencing waiver approval that we received in January to establish a work requirement or a community engagement requirement for a portion of our population. And we're really talking about approximately 120,000 enrollees, able-bodied adults ages 19 to 49, that will be required to demonstrate that they're either employed, engaged in employment, or seeking employment rather, or engaged in employment support and development activity. There are a number of exemptions, I think 13 in total, if I'm not mistaken. American Indians being the most notable for us because there's a state statutory requirement around that exemption, and it was a long, hard-fought battle with our federal partners to obtain that exemption. I'm happy to say that we did ultimately obtain it. But again, a portion of our population beginning in, we're saying spring to summer of 2020, when we stand up work requirements, will be required to demonstrate that they're either employed or seeking employment or involved in some sort of engagement activity, related engagement activity. I will say, I think the exciting part of the work requirement effort is it really ties nicely to our interest in social determinants. And so what I'm really thinking about is how can we really broaden our conversation around employment for Medicaid enrollees, ensuring that we're providing employment supports and services to individuals throughout our populations when they demonstrate interest in becoming employed, and ultimately sort of creating that path to independence for individuals that we serve. So I think it does fit nicely into that conversation, but we have work to do over the course of the next year to really build out our network of providers that are able to offer that type of support.
Tell me what opportunities, what challenges, and what sort of degree of cultural competency does Access need to integrate and work with tribal communities when it comes to Medicaid redesign? How has that opportunity and that challenge presented itself, and how has the agency responded?
Oh, that's a great question. So as you know, we have 22 tribes in Arizona. So the best example that I'll give of sort of the level of understanding around the work that we do was when we in fact were in negotiation with CMS around the American Indian exemption for work requirements. They continually referred to the Indiana model. The Indiana model, where there was one tribal community on the border of the state that had established their own work program, and they couldn't understand why we wouldn't be able to do the same with tribes in Arizona and have each of the tribes establish their own work program. And I kept saying, so you're talking about 23 separate work programs. And I think that's really what stands out in my mind in terms of working with tribal communities in Arizona. Each tribe is unique, and so our work really is focused around meeting the needs of individual tribes and where they sit in their communities, whether it be an urban-based tribe like Gila River, or in the southern part of the state, Tohono O'odham, or an extremely remote and rural tribe like the Hopi Nation up in the northeastern part of the state. We conduct regular quarterly tribal consultation meetings, which are incredibly informative to us in terms of guiding our work around how to serve tribal communities, and oftentimes formative for us in helping us to understand what the needs are of the program more generally. Tribes are often on the forefront of that conversation, and so we really use those tribal consultation meetings to inform programmatic developments more generally.
I can't tell you how much we appreciate your personal engagement and support as we have built our first event here this year. Absolutely. How can this group help you do your job?
Oh my gosh. Well, so at Access, we are very committed to stakeholder engagement. I think the success of our program has historically really been supported by our partnership with community stakeholders and private sector entities like our contracted managed care organizations. So what I would ask from this group is, over the course of the next 14 months, as we start to really frame out that waiver renewal package, I would ask for your ongoing engagement around what that needs to look like. It's a big conversation when we talk about social determinants of health, and there's a lot of discussion now, as Marcus, I think, is somewhere in the room, will tell you, around, should we focus on a singular area where we've seen some level of success like housing, or should we cast a wide net and ensure that we're meeting individuals' needs? How do we support providers, which is, I think, why the tech component of this conversation is important. How do we support providers who are already overwhelmed by the administrative burden that we pose through our program, to integrate a conversation around social service needs into their daily workflow? And so I think we will need to hear from all of you in that discussion, and we're only going to be successful if we do. And so I really appreciate the interface and the opportunity to talk with my colleagues and friends throughout the community. And I think an event like this really fosters that kind of discussion.
Jami Snyder, Director of Access. Let's give her a round of applause. Thank you very much.